അതായത് പിന്നെ ഓണ്ടോട്ടെ സിസ്റ്റം പേടിയാണ്. അത് ഷെമീറായിട്ട് അഡ്ജസ്റ്റ് ചെയ്തിട്ടുണ്ടെന്നാണ്
ആയോ ആളായോ?
ഇല്ല സർ.
ഒരു 2 മണിക്ക് തന്നെ തുടങ്ങാം അല്ലേ? വരുമോ?
ഓക്കെ സർ. Karina Macarena Macarena Karina Macarena Macarena Karina.
തുടങ്ങിയാലോ?
Yes, sir.
Okay. Good afternoon, all. Have you had your lunch? All of Avarna.
Yes, sir.
Okay. So today's afternoon session is on acute post-streptococcal glomerulonephritis. So before going to the topic proper, I would like to give an introduction to glomerulonephritis. Glomerulonephritis, otherwise called nephritic syndrome, not nephrotic, it's nephritic syndrome. It's a syndrome characterized by four major manifestations like hematuria, oliguria, edema, and hypertension. So these are the features of nephritic syndrome. All cases of glomerulonephritis usually presents with these symptoms. This will not be there at the same time. All these symptoms may not be there. At a time, only one symptom may be there, then it evolves into other symptoms. So even it can present with the hypertension only. The later on, it can progress to hematuria, oliguria, and edema. So these four symptoms are characteristic of all conditions that presents with the nephritis. It's called nephritic syndrome. So this is the etiology of nephritic syndrome. Or not for the post-streptococcal glomerulonephritis alone, other conditions that can cause nephritic syndrome with the hematuria, oliguria, edema, and hypertension. One of the commonest etiology of glomerulonephritis is post-infectious. Post-infectious mainly due to bacteria. Among the bacteria, the commonest agent is Streptococcus. Group A, beta hemolytic streptococcus is the commonest agent causing acute glomerulonephritis. And other bacteria causing post-infectious glomerulonephritis are Staphylococci, then Meningococci, Treponema pallidum, Leptospira. These are the bacterial agents causing post-infectious glomerulonephritis. Then viruses can also cause post-infectious glomerulonephritis, like Epstein-Barr virus, CMV virus, and hepatitis B, hepatitis C viruses. So these viral infections can also cause post-infectious glomerulonephritis. Then protozoal infection, mainly malaria, Plasmodium falciparum and Plasmodium malariae can cause glomerulonephritis. And glomerulonephritis can follow severe infections also. Severe infections like shunt infections, usually shunt in the ventriculoperitoneal shunt. Infection of the VP shunt can cause glomerulonephritis. Then infection of prosthesis, prosthetic valves, or even infective endocarditis can cause post-infectious glomerulonephritis. So these are the various etiology for post-infectious glomerulonephritis. Then another group of conditions that can present with glomerulonephritis is systemic vasculitis, like HSP, Henoch-Schönlein purpura, otherwise called HSP, Henoch-Schönlein purpura. Then polyarteritis nodosa, PAN, polyarteritis nodosa, Wegener's granulomatosis. These are the examples of systemic vasculitis causing presenting with the glomerulonephritis, nephritic syndrome. Other conditions like membranous proliferative glomerulonephritis, IgA nephropathy, hereditary nephropathy, SLE, etc., can also cause acute glomerulonephritis, presenting with the nephritic syndrome. MPGN is membranous proliferative glomerulonephritis. So these are the differential diagnosis of a child or person presenting with the nephritic syndrome. Today we are going to discuss about the commonest and most common condition causing glomerulonephritis or nephritic syndrome in child. Like this is the post-streptococcal glomerulonephritis. So now about the PSGN proper, post-streptococcal glomerulonephritis. So PSG usually follows a skin infection, pyoderma, or a throat infection, or streptococcal pharyngitis. Usually pyoderma or pharyngitis. It is after the infection, after the resolution of the infection, usually these symptoms occur in PSG. There is a latent period from the point of infection to the onset of post-streptococcal glomerulonephritis. So common agent is group A beta hemolytic streptococcus. Not all strains of group A beta hemolytic streptococcus will not cause glomerulonephritis. There are certain strains. Only few strains can cause post-streptococcal glomerulonephritis. So these are the strains causing sore throat that can produce glomerulonephritis are strains like M1, M4, M25 and some strains of M12. These are the nephrogenic strains that presents with the sore throat. M1, M4, M25 and M12, only few strains. Which is the other condition that is caused by streptococcal infection? Anyone? Any other condition that can occur as following?
Rheumatic heart fever.
Which one?
Rheumatic heart fever.
Rheumatic fever, acute rheumatic fever. Okay. Acute rheumatic fever is also a post-streptococcal condition. Here, in acute rheumatic fever, there are many strains that can cause acute rheumatic fever. Many strains of group A beta streptococcal, but here only few strains. And pyoderma causing strain is a serotype M49. Only one strain of pyoderma causing streptococcal produces nephritis. So this is important because rheumatic fever, following rheumatic fever, we usually use prophylaxis. But here in PSGN, there is a chance of recurrence is less because the only few strains causes PSGN and immunity here is type specific also. There is no cross immunity. So chance for occurrence of PSGN is very rare compared to rheumatic fever. So prophylaxis is not required in PSGN, unlike rheumatic fever. And the age group for PSGN is post-streptococcal glomerulonephritis 5 to 12 years. So it will take some time for this much of immune response to take place. So 5 years is the minimum age. It is very rare below 3 years of age. Below 3 years of age, you have to think of other causes of nephritis. PSGN is not a diagnosis below 3 years of age. And 5 to 12 here also it is similar to rheumatic fever. Rheumatic fever is also common in the school going children, like 5 to 15 years of age. And there is a latent period between the infection and the onset of PSGN. For following a pyoderma, it takes around 3 to 6 weeks. 3 to 6 weeks following a pyoderma, and following pharyngitis, streptococcal pharyngitis takes around 1 to 2 weeks for the onset of glomerular nephritis. So if the onset of nephritis is within less than 1 week of infection, it is unlikely to be post-streptococcal glomerular nephritis, because you have to think of other causes of nephritic syndrome, because it takes some latent period for the immunological response. Actually, it is an immune reaction. So it takes some time for the immune reaction to take place. So if the onset is less than 1 week, think of other etiologies of rheumatic fever. Glomerular nephritis. Now about the etiopathogenesis. What is etiopathogenesis? There are few theories are there. There is no consensus of opinion, but there are certain theories are there. One theory is immune complex formation. That is circulating immune complex formation with the streptococcal antigens, and it gets deposited in the glomerular basement membrane. That is one theory. Immune complex formation of streptococcal antigens and subsequent deposition in the glomerular basement membrane. Second theory is molecular mimicry, like in rheumatic fever. Molecular mimicry, circulating antibodies elicited by the streptococcal antigens will react with the normal glomerular antigens. So circulating streptococcal antibodies that are produced due to the antigens, streptococcal antigens, will cross-react with the normal glomerular antigen. That is another theory of for the etiopathogenesis of post-streptococcal glomerular nephritis. And another theory is complement activation, because these streptococcal antigens can get deposited in the glomerular membrane, and this will initiate a complement activation directly. This can directly initiate a complement activation. So these are the theories of etiopathogenesis of post-streptococcal. So anyway, all these mechanisms will produce a inflammation and proliferative response within the glomerular. All these mechanisms produce a inflammatory response within the glomerular. And this will lead on to reduction in the glomerular filtration. That because of the reduced renal blood flow and reduced permeability of the basement membrane, this will lead on to reduced GFR. So this immune complex formation or molecular mimicry or even complement activation produce an inflammatory response. It will produce a proliferation within the glomerular and reduction in the renal blood flow and reduction in the permeability of the glomerular basement membrane. This will ultimately lead on to reduction in the glomerular filtration rate. So reduced GFR is characteristic of the glomerular. In our case, the glomerular nephritis, GFR will be reduced. Now about the pathology. What are the pathological histopathological changes seen in PSGF? Or under light microscopy, the glomeruli appear enlarged because of inflammation. Glomerular enlarged and ischemic, and capillary lobes are narrowing also. That indicates the reduced blood flow. Actually, this glomeruli appear bloodless on light microscopy examination. And on immunofluorescence examination shows granular deposits of IgG and complement along the capillary walls, glomerular capillary. Granular deposits. These deposits are called lumpy bumpy deposits. The term called lumpy bumpy deposits in immunofluorescence. And electron microscopy shows deposits on the subepithelial side of the glomerular basement membrane. On electron microscopy, deposits on the subepithelial side of the glomerular basement membrane. Inflammatory deposits are seen on the subepithelial side of the glomerular basement membrane. These appears as hump. The description is like appearance is like a hump in electron microscopy. So these are the histopathological changes seen in post-structural glomerulus. So three are there: light microscopy, immunofluorescence, and electron microscopy. Then about the clinical features, presentation of the post-structural glomerulus. So it has got a rapid onset, sudden onset of symptoms. The onset can be maybe as hematuria, or sometimes with edema, or maybe as a secondary to hypertension, headache and drowsiness may be the presentation. Anyway, the presentation will be rapid in onset, and the edema is characteristic. Edema is usually manifests around the eyes, around the eyelids, usually around the upper eyelid or the upper eyelid. Initial edema will be over the upper eyelid because the tissue resistance is less over the around the periorbital area. That is why, and the renal edema usually manifests in the early morning hours also. And when the day progresses, edema usually subsides in the initial days, in early phase. So puffiness around the eyes, because this edema in post-structural glomerulonephritis is due to the increased intravascular volume. This increased intravascular volume causes increase in the hydrostatic pressure, increased intravascular hydrostatic pressure. This causes leakage of fluid into the interstitium. Increased intravascular hydrostatic pressure and leakage of fluid into the interstitium. Since the tissue resistance is less in the around the eyes, it manifests around the eyes, initially around the eyes. So early morning edema, periorbital puffiness is characteristic of renal edema. It is not the characteristic of nephritis only. When nephrotic syndrome also, edema manifests around the eye. Initial edema will be around the eyes and in the early morning hours. And the description of urine in post-structural glomerulonephritis is like cola colored. It is uniformly colored, not like in the lower urinary tract infection. In lower urinary tract infections, they can present with the terminal or initial hematuria. In the initial part of the micturition, there will be blood in the urine, or in the terminal part, in cystitis and all, there will be terminal hematuria. When the bladder contracts, blood will be there in the urine. Here in nephritis, it is uniformly stained. It is called cola color. This cola color is attributed to acid hematin. Acid hematin. This cola color, or another description of urine is smoky urine, or another description is burgundy urine. These are the description of hematuria in glomerulonephritis, because this color indicates the glomerular origin of the blood. That is in the upper urinary tract. The origin of hematuria is in the upper urinary tract. And oliguria is reduced urine output, is characteristic of glomerulonephritis. Oliguria is not seen in nephrotic syndrome. That is an immediate DD of the differential diagnosis of a renal edema, nephrotic syndrome. So in nephrotic syndrome, there will not be oliguria. And hypertension. Hypertension can present with symptoms like headache, vomiting, and other features or raised intracranial tension. Even they can present with encephalopathy, hypertensive encephalopathy, like altered sensorium, convulsions, and coma. So these are the usual clinical features of glomerulonephritis, post-structural glomerulonephritis. And there are atypical presentations also. Atypical presentations are, it can present with convulsion. Convulsion secondary to a hypertension encephalopathy. Increase in the uncontrolled hypertension can lead on to encephalopathy, and that can present with the convulsions. And pulmonary edema. This initial presentation may be pulmonary edema with the left ventricular failure. Child may present with cough, dyspnea, and basal crepitation. When you auscultate over the chest, you will get basal crepitations, and orthopnea also. These are all indicative of pulmonary edema. This pulmonary edema is due to volume overload, increase in the intravascular volume. Another presentation is AKI, acute kidney injury. In all cases of acute kidney injury, you have to think of post-structural glomerulonephritis in a child between 5 and 12 years of age. And some children may present with the nephrotic syndrome also. Hematuria with the nephrotic range proteinuria. That is called nephritic onset of nephrotic syndrome. That's another type. So it can present with the features of nephrotic syndrome also. So in the case of nephrotic syndrome, if hematuria is also there, think of nephritis. But usually in post-streptococcal glomerular nephritis, it is very rare. Nephrotic range proteinuria is very rare. It's an atypical presentation for post-streptococcal glomerular. Other forms of nephritis, other causes of glomerular nephritis sometimes present with for nephrotic features and nephrotic syndrome features also, nephrotic range proteinuria. But in post-streptococcal glomerular nephritis, nephrotic range proteinuria is very rare. So these are the atypical presentations of PSGN. Then about the investigations, lab findings in PSGN, post-streptococcal glomerular nephritis. Urine. First, you have to examine the urine. Urine for microscopy. Microscopy, you look for RBCs, RBC casts and WBC. These are characteristic of glomerular nephritis. RBCs, RBC casts and WBCs. RBCs are due to glomerular inflammation. Glomerular, it indicates glomerular inflammation. RBC cast also indicates the glomerular origin of the hematuria. And WBC can also be there in the urine. It does not indicate any infection, but it indicates the inflammation of the glomeruli, WBCs. So you can do a urine culture and sensitivity to rule out an infection. But WBC count may outnumber the RBC in the urine sometimes, but it does not indicate an infection. It is due to inflammation. And dysmorphic RBCs are characteristic of glomerular hematuria, dysmorphic. More than 50, using a phase contrast microscopy, you can identify dysmorphic or crenated RBCs. So crenated or dysmorphic RBCs more than 15% is indicative of glomerular origin of the hematuria. So all these findings differentiate the glomerular hematuria from a lower urinary hematuria. Lower urinary hematuria causes are mainly urethritis and cystitis. So dysmorphic RBCs and RBC cast helps to differentiate the lower urinary hematuria from a glomerular hematuria. And look for proteinuria also, 1+ or 2+ proteinuria, that is abnormal range proteinuria can be there along with the hematuria, 1+ or 2+ proteinuria. 3+ or 4+ proteinuria is called nephrotic range proteinuria. Here it is in post-streptococcal glomerular nephritis, 3+ 4+ proteinuria is very rare. It's a typical presentation. And urine culture is to rule out a urinary tract infection, especially cystitis, urethritis, or pyelonephritis. And blood investigation, first you have to do a complete blood count, CBC. CBC, you look for hemoglobin values are usually reduced. This is mainly due to the dilutional anemia. Dilution, because HB will be on the lower side because of the hemodilution. Because there is accumulation of fluid and it will lead on to hemodilution. So nephritis is a condition with the hemodilution, and nephrotic syndrome is a condition with the hemoconcentration. So that is one difference between nephritis and nephrotic syndrome. So CBC usually we get anemia, and ESR may also be elevated because of the inflammation. Elevated ESR is also a usual finding. And RFT, blood urea and creatinine, is usually elevated in glomerular nephritis because of the reduced GFR. It indicates a reduced GFR, elevated blood urea and creatinine. And serum electrolytes. Serum electrolytes usually shows hyponatremia. Hyponatremia is usually dilution because of the fluid retention. Hyponatremia is dilution. And another important finding in serum electrolytes is hyperkalemia. Hyperkalemia is one of the complications of glomerular nephritis. So always do serum electrolytes and look for serum sodium and potassium. And to prove that for evidence of streptococcal infection, you have to do a ASO titer, anti-streptolysin titer, or anti-DNase B titer. ASO titer is usually for the for following sore throat, the ASO titer becomes positive. And following the pyoderma, the ASO titer may not be positive because the skin lipids will neutralize the streptolysin antibody. So there may not be elevated ASO titer following a streptococcal pyoderma. So in that case, to prove there is streptococcal pyoderma, anti-DNSB is the investigational choice. Anti-DNSB or hyaluronidase testing, anti-hyaluronidase testing can also be done. So ASO titer is mainly for streptococcal sore throat, evidence of streptococcal sore throat, and elevated anti-DNSB is for pyoderma. And look for serum C3 also. As I said in the earlier slide, the etiopathogenesis, it is an immune complex. There is an immune complex formation. That is a reason for one of the etiopathogenesis for the glomerulonephritis. Here, serum C3 will be reduced. On all cases of post-streptococcal glomerulonephritis, C3 will be reduced. So, if C3 is normal, think of other etiologies of glomerulonephritis. So, look for evidence of streptococcal infection by ASO titer and anti-DNSB, and utilization of complement by looking for the C3 levels. If C3 is normal, think of other diagnosis. And chest X-ray and ECG mainly to rule out complications. Like chest X-ray, you look for any features of pulmonary edema or volume overload. You look for if pulmonary edema is there, there will be cardiomegaly and pulmonary markings will be prominent, and it gives usually the typical appearance of the X-ray in pulmonary edema is battering appearance. There will be prominent hilar area will be very prominent hilar region because increased opacity in the hilar regions. So that gives appearance of a battering. That indicates volume overload and pulmonary edema. And ECG you look for complication like hyperkalemia, any changes of hyperkalemia. What are the changes of hyperkalemia in ECG? Anybody? ECG appearance. Your initial topics were over, no? Hyperkalemia is already taken. Anyone?
Sir, ST segment elevation.
Is it elevation or depression?
Okay.
It's depression, depression of the ST segment. Then before that,
Tall peak T waves.
very good. Tall peaked T waves, ST depression of the ST segment. Then widening of the PR, prolongation of PR interval and widening of the QRS. These are the changes seen in hyperkalemia. So in ECG, you look for changes of hyperkalemia. And ultrasonography. Ultrasonography is done, which is not routinely indicated. It can be done to rule out any anomalies in like any malformation in the kidney. Usually, ultrasonography shows enlarged kidneys, bilaterally enlarged kidneys with increased parenchymal echogenicity. That is the usual picture in ultrasonography. So they usually give a report like a bilateral medical renal disease. It is in both in nephritis and nephrotic syndrome, kidneys will be enlarged and hyperechoic. So these are the lab findings. And finally, renal biopsy. Renal biopsy is not indicated in all cases of post-streptococcal glomerulonephritis. Only specific indications are there for renal biopsy in post-streptococcal glomerulonephritis. One is systemic features. So glomerulonephritis presenting with the systemic features like fever, rash, joint pain. These are all indicative of vasculitis or collagen diseases. So in that case, or presenting with the organomegaly, nephritis presenting with the organomegaly, then you have to do a renal biopsy to confirm the diagnosis. Systemic features like fever, rash, joint pain, organomegaly. Then absence of serological evidence of streptococcal infection. If ASO titer is normal, anti-DNSB is normal, and C3 level is also normal, think of other etiologies. In that condition, you have to do a renal biopsy to confirm the diagnosis. And third indication for renal biopsy is mixed features of glomerulonephritis and nephrotic syndrome. So that means nephritic onset and nephrotic syndrome. So both the features are there. Nephritis and nephrotic syndrome features are there. You have to do a renal biopsy. And rapid progression of the condition, rapid progression of symptoms like uremia, rapidly progressing to uremia and acute kidney failure. Then also it is an indication for renal biopsy. Then delayed resolution. Even in the case of post-streptococcal glomerulonephritis, you are giving proper management, appropriate treatment is being given, support is given, but there is delayed resolution. Like if gross hematuria persisting beyond 4 weeks, gross hematuria persisting beyond 4 weeks is an indication. It indicates a delayed resolution, and you have to look for other etiologies. And proteinuria, nephrotic range proteinuria persisting beyond 2 weeks. In nephritis also, in the early phase, there you can get nephrotic range proteinuria, but it usually subsides by around 2 weeks. 2 weeks. Then if it persists, nephrotic range proteinuria persists beyond 2 weeks, it's an indication for renal biopsy. Then proteinuria persisting, microscopic proteinuria persisting beyond 6 months of age. Proteinuria, not microscopic, abnormal proteinuria persisting beyond 6 months of age is an indication for renal biopsy. Another indication is low C3 even after 12 weeks of the onset of the condition, because C3 is initially C3 will be low and gradually it becomes normal by around 6 to 8 weeks. C3 becomes normal in post-structural glomerulonephritis. If it is not getting normal even after 12 weeks of the onset of the condition, think of other etiologies like other conditions causing low C3 and nephritis are SLE, lupus nephritis, and infective endocarditis. And in the earlier side, it is MPGN, membrana proliferative glomerulus. In all these conditions, C3 will be persistently low. And shunt infection also. Shunt infections also produce a persistent low C3. So here in post-streptococcal glomerulonephritis, C3 is low in the initial phase only. For 6 to 8 weeks, C3 will be low, then it becomes normal. So if persistent low C3 beyond 12 weeks is also an indication for renal biopsy. Then the differential diagnosis of PSGA. First differential diagnosis is nephrotic syndrome itself. That is another renal cause for edema, nephrotic syndrome. Nephrotic syndrome, there will be classes of nephrotic syndrome also. And after that, you can easily differentiate between nephrotic and nephritic syndrome. And second is HUS, that is hemolytic uremic syndrome. Hemolytic uremic syndrome usually presents with the pallor, edema, oliguria, and bleeding also, bleeding manifestation because of thrombocytopenia. So in HUS, usually we get a history of diarrhea just 1 or 2 days before the onset of this edema, pallor, and oliguria. So usually certain strains of E. coli and Shigella produces HUS, hemolytic uremic syndrome. And by peripheral smear, you can get the diagnosis of HUS by looking at the microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia and thrombocytopenia will be there in the peripheral smear in hemolytic uremic syndrome. Another differential diagnosis is IgA nephropathy. IgA nephropathy is a condition that presents with a recurrent hematuria. So in the initially I said there is no chance of recurrence of post-streptococcal glomerulonephritis. Chance of recurrence is very less in PSGA. But in IgA nephropathy, the presentation is like a recurrent hematuria. So when there is recurrence of hematuria, always think of IgA nephropathy. And IgA nephropathy, usually there is no latent period between the infection and the hematuria. So IgA nephropathy is otherwise called it as thin pharyngetic condition. Along with the sore throat, there will be hematuria. Here in VSGN, after the resolution of sore throat, then only nephritis manifests. But in IgA nephropathy, it goes along with the respiratory or throat infection, IgA nephropathy. And hereditary nephritis, otherwise called Alport syndrome, is a differential diagnosis. Alport syndrome can present with the features of glomerulonephritis. Here also, you ask for a family history of renal disease because it's a autosomal dominant condition. So you always ask for family history of renal disease and ask for any deafness in the family. Deafness is an association of hereditary nephritis or Alport syndrome. And SLE is a differential diagnosis. SLE usually seen in girl children, and other manifestations SLE will be there, like skin rashes, polyserositis, hematological manifestations, and neurological manifestations will be there in SLE. Also, SLE is also a differential. And Other system also edema, like a cardiac failure. Cardiac failure we can easily differentiate by the cardiomegaly, palpitation, exertion, dyspnea, dependent edema itself. Here in cardiac failure, edema manifests in the dependent areas, unlike in renal edema, the onset of edema is around the eyes, but in cardiac failure, onset is on the dependent parts, like in the foot, lower limbs. And hepatic edema is another differential diagnosis. So you have to look for any features of chronic liver disease like gynecomastia, spider nevi, then pallor, other vitamin, fat soluble vitamin deficiencies of fat soluble vitamins, etc. To rule out a hepatic edema. Hepatic edema usually manifests as the onset is around the abdomen, like as ascites, starts as ascites and spreads to the other parts of the body because of hypoalbuminemia. So these are the differential diagnosis of PSGL. Now about the treatment. So appropriate charts should be maintained in the treatment, but appropriate charts should be maintained. This is very important. There are almost 4 or 5 charts are there. One is the intake output chart. You have to measure the intake and output daily. Intake the fluid recommendation is based on the intake output chart. So intake output chart should be maintained. Then daily BP recording, at least twice daily BP should be recorded to look for any hypertensive changes. Then daily weight recording to know the progression of edema. Daily weight recording must be there. Then abdominal girth should be looked for. Abdominal girth. Usually nephritis will not manifest as post-operative glomerular will not manifest as ascites. When ascites is there, you have to think of more like a nephrotic syndrome. So even though in post-operative glomerular nephritis also we have to measure the abdominal circumference, abdominal girth daily. Then another chart is the urine albumin chart, daily urine albumin chart. This is to look for the progression of proteinuria, whether proteinuria is becoming nephrotic range or not. So 5 charts should be maintained: intake output chart, BP chart, daily weight recording, abdominal girth, and albumin chart. Then salt should be restricted. No ordered salt should be given. Salt restriction is the must till the diuresis begin. Till the diuresis begins, salt should be restricted. No ordered salt should be given. Salt intake should be less than 1 gram per day. And next is the restriction of potassium. Here, so in glomerulonephritis, the treatment is mainly supportive. So it is a self-limiting condition. Just support is enough. If complications are developing, then only treatment is required. So restriction of potassium is important because hyperkalemia is a feature or is a complication of glomerulonephritis because of the retention. Fluid retention and electrolyte retention is there in glomerulonephritis. So potassium will be high in glomerulonephritis. So potassium rich foods like fruits should be avoided. Fruits, especially this coconut water should be avoided. It contains a lot of potassium. Then chocolates, nuts, cashew nuts should be restricted in children with PSGA. And fluid restriction. Fluid requirement is calculated based on the intake output chart. So fluid should be restricted to previous days urine output plus insensible loss. So fluid should be given as previous days urine output plus insensible loss. Insensible loss is calculated with the formula 400 ml per meter square per day is the insensible loss. So for in a child it is around 20 ml per kg per day. In a child it is around 20 ml per kg per day is the insensible loss. It's a rough calculation. Actually, you have to measure the body surface area of the child and calculate with 400 ml per meter square per day. That is the actual calculation. 400 ml per meter square per day. So previous days urine output plus insensible loss is the fluid intake for that day. So this should be continued till diuresis begin. Fluid restriction should be continued till diuresis begin. And restriction of proteins. Protein should be restricted because there is a chance for uremia. Urea will be elevated glomerulonephritis. So as far as the urea is elevated, protein should be restricted. Protein intake should be reduced less than 1 gram per kg per day. Less than 1 gram per day. That too, this protein intake should be good quality protein also. It should be given as good quality protein. Intake should be restricted, and the protein that is being given should be of good quality. That is, animal proteins are the good quality proteins. So protein restriction should be there, and good quality protein should be given in children with nephritis. And bed rest is also indicated. Bed rest, especially when the child is having hypertension, till the hypertension resolves, bed rest is indicated, and activity should be restricted till hematuria, gross hematuria subsides. So bed rest is for hypertension till the hypertension subsides, and activity restriction till gross hematuria subsides. And antibiotic indication for antibiotic. Antibiotic indication is very less. Indication for antibiotics is less in post-operative, because most of the time infection will there will not be any evidence of infection at the time of onset of post-octococcal glomerulonephritis. Sometimes this residual lesions may be there, like pyoderma. In that conditions, if residual streptococcal infection is there at the time of presentation of post-octococcal glomerulonephritis, you can give antibiotic like penicillin. Penicillin, procaine penicillin or custom penicillin can be given, or even oral penicillin can be given for 10 days. Antibiotic also 10 days. In persons who are allergic to penicillin, you can give erythromycin. So antibiotic is not a must. If there is evidence of residual streptococcal infection, then only antibiotic is indicated. And diuretics. Diuretic is indicated because the condition is here the dominant manifestations due to the fluid overload. So diuretics are indicated. Diuretics will reduce the decrease the edema and volume overload. The usually given diuretic is furosemide. Furosemide at a dose of 2 milligram per kg per dose twice daily. 2 milligram per kg per dose twice daily. So diuretic usually we given for PSGN. So this is the treatment for PSGN. Then about the complications and their management. What are the complications and how will you manage the complication? One of the common complication is the acute renal failure. It can present with the AKI. So AKI is usually managed with the fluid restriction and repeated dose of diuretics. Fluid restrictions like previous days urine output plus insensible dose, and repeated dose of diuretics. And always monitor the child with the acute renal failure. Monitor with the biochemical values and clinical parameters, and look for any deterioration. So if supportive treatment is not producing any improvement, or if the condition is deteriorating, it is an indication for peritoneal dialysis. Acute renal failure not responding to conventional or supportive management, peritoneal dialysis indicated. And second complication, pulmonary edema and acute left ventricular failure. Here, as I said earlier, pulmonary edema usually manifests with the cough, dyspnea, orthopnea, and basal crepitations. When you auscultate over the chest, crepitations will be there in the basal parts of the lung, and there will be cardiomegaly also in pulmonary edema with the left ventricular failure. Here, also you have to give oxygen. Treatment is with oxygen, diuretics, multiple dose of diuretics may be given, and intermittent positive pressure ventilation, IPPV, intermittent positive pressure ventilation is also indicated in pulmonary edema. Here also, if not responding to conventional management, peritoneal dialysis is indicated. Pulmonary edema not responding to conventional management, PD is indicated, peritoneal dialysis. Then another complication or presentation itself is hypertension. Hypertension is mainly the etiology of hypertension in post-octococcal glomerulonephritis, mainly fluid overload. One of the etiology for hypertension in PSGN is fluid overload. There are other factors also contribute to hypertension. So fluid restriction and repeated dose of diuretics will help in reducing the hypertension in the initial phase. So fluid restriction and salt restrictions also will help to reduce the hypertension, and repeated dose of diuretics like furosemide. If not responding to this fluid restriction, salt restriction and diuretics, then only antihypertensive medications are indicated. The common antibiotic antihypertensive given in management of hypertension in PSGN is nifedipine. Nifedipine at a dose of 0.5 milligram per kg per dose, 6th hour is being given. 0.5 milligram per kg per dose, 6th hour is the dose of nifedipine in hypertension management. Other antihypertensive like alpha medial dopa, hydralazine, beta blockers can also be used in management of hypertension. The common agent, common drug is nifedipine. And ACE inhibitors are not used for control of hypertension in PSGN. ACE inhibitors like captopril and enalapril actually it is contraindicated because captopril and enalapril produces hyperkalemia. So in PSGN itself, the presentation itself it's a complication. Hyperkalemia is a complication of PSGN. So we usually don't give this ACE inhibitors, the enalapril and captopril for the management of hypertension. Sometimes hypertension can present with hypertensive encephalopathy like severe headache, vomiting, drowsiness, altered sensory alteration, coma, and seizures. Hypertensive encephalopathy is also initially managed with the antihypertensive, and if not responding to antihypertensive measures, then also hypertensive encephalopathy also should be managed with the peritoneal dialysis. If not responding to routine antihypertensive measure, hypertensive encephalopathy is managed with the peritoneal dialysis. And another complication is persistent acidosis. When you look at the pH, when you look at the ABG, pH will be persistently low on the lower side. That is, pH less than 7.2 is an indication for peritoneal dialysis. Persistent acidosis is an indication for dialysis. Uremia also, if uremia producing complications like pericarditis or uremia producing CNS deterioration of the CNS status, or uremia is producing bleeding. Uremia produces bleeding because it interferes with the urea interferes with the platelet function. So in uremia there will be platelet dysfunction and this will produce bleeding. So if uremia producing bleeding or deterioration of CNS status or pericarditis, it is an indication for peritoneal dialysis. So another complication is hyperkalemia. Hyperkalemia, the treatment is like hyperkalemia is when the serum potassium level is above 5.5 milliequivalent. So the normal potassium level is between 3.5 to 5.5 milliequivalent per liter. So if it is more than 5.5, it is hyperkalemia, and if it is more than 6.5 milliequivalents per liter, it is an indication for peritoneal dialysis. If it is more than 6.5, if between 5.5 and 6.5 hyperkalemia, you can manage with the medical measures like 10% calcium gluconate IV, 10% calcium gluconate IV, 0.5 ml per kg per dose over 10 minutes. It should be given as a slow infusion over 10 minutes, 0.5 ml per kg per dose of 10% calcium gluconate. And cardiac monitoring should be done during the infusion because calcium gluconate can produce bradycardia. So if heartbeat falls below 20 beats from the baseline value, then you have to stop the infusion and wait for the heart rate to pick up. Then only continue with the infusion. Or sometimes you have to avoid, disconnect the infusion also if bradycardia is persistent. So 10% calcium gluconate can be given when there is hyperkalemia. And another treatment for hyperkalemia is 7.5% sodium bicarbonate, soda bicarbonate. 7.5. It is given as a dose of 2 milliliter per kg per dose. 2 milliliter. So this soda bicarbonate will cause shift of the extracellular potassium into the intracellular compartment. So that will produce hypokalemia, reduction in the potassium levels. Another drug being used in hyperkalemia management is 50% glucose with insulin. 50% glucose in a dose of 1 ml per kg with the regular insulin, 0.1 unit per kg is given as a slow infusion. 50% glucose, 1 ml per kg with regular insulin 0.1 unit per kg. It is given as a slow infusion. It will also produce intracellular shift of the potassium. So it will produce hyperkalemia. Another agent being used for hyperkalemia management is nebulization with the beta 2 agonists like salbutamol. So it will produce hypokalemia. Usually helps to lower the potassium levels. Or finally, you can, if hyperkalemia is not responding, you can even use ion exchange resins. Ion exchange resins can also be used. So if not responding to usual conventional hyperkalemia management, or if the potassium levels are persistently elevated above 6.5 milliequivalent, then it is an indication for peritoneal dialysis. Now about the prognosis. Prognosis for PSG and postoperative glomerular affairs has got an excellent prognosis if you only requires supportive management. When complications develop, generally there is problem, because if you give a proper supportive treatment, prognosis will be very good prognosis. And usually the edema settles in around 10 days. Edema is the first to subside. Edema settles in about 10 days, and hypertension usually resolves in 2 to 6 weeks. Even with you can stop antihypertensive after 2 to 6 weeks. And proteinuria disappears in 6 weeks. So mild proteinuria may be there, but gross proteinuria disappears in around 8 weeks. And gross hematuria disappears within 1 month. Within 4 weeks, gross hematuria. But even microscopic hematuria can persist for even up to 1 to 1.5 years. So gross hematuria, visible hematuria will disappear by 1 month, within 1 month, and microscopic hematuria can persist even up to 1 year in case of PSGN. And recurrence of PSGN is unusual, as I said earlier, because the only few strains of Streptococcus causes PSGN, and the immunity is type specific also. There is no cross immunity. In acute rheumatic fever, there is cross immunity. Infection with other strains can also produce rheumatic fever. Here, immunity is type specific, then it will not cross react. And the strains are limited also. Nephrogenic strains are limited in number also. So recurrence chance for PSGN is very less. So no prophylaxis is required. This is a usual question being asked in clinical examination. Why both are rheumatic fever and PSGN are both are sequelae or late manifestations of only rheumatic fever requires prophylaxis. This is the reason recurrence is very less than PSGN. So that's all about PSGN. If you have any queries, you can ask for. Any doubts you can ask for. This is this class is just to sensitize you about nephritis and nephritic syndrome. Today itself you read about the PSGN and the your textbook of PA. So any doubts, Rajat? Any doubts?
No, sir.
Rahul Meena is there? Rahul is there? No. Femina, do you have any doubt?
No, sir.
Okay. So today itself you read about the PSGN and nephrotic syndrome. These are for your theory classes, theory examination, clinical examination. Both these two conditions are very important: nephritis and nephrotic syndrome. Nephritic syndrome and nephrotic syndrome. In the discussion about the clinical discussion also, this is important. For theory also, this hyperkalemia management is a usual question, and indications for renal biopsy is a usual question. Then lab findings both in nephritis and nephrotic syndrome. These are usual questions in theory also. So it's an important topic. Read from the textbook also. And if you have any doubt, you can ask for in the during your clinical classes. Okay. Aparna, Narta.
Yes, sir.
Attendance വെക്കാറുണ്ടോ?
WhatsApp ചെയ്യാം sir.
ചെയ്യുമല്ലോ. Okay, okay. Okay, stop.
Thank you, sir.
Okay, welcome.